A few weeks ago, I shared exciting news about Nipocalimab receiving Fast Track designation from the FDA for treating adults with moderate to severe Sjogren's disease. Since then, I have received numerous questions from many of you asking for more details, particularly about who might qualify and what potential side effects we should be aware of if we are considering this treatment option. Hi, everyone. My name is Dr. Carol Wada. I'm a board-certified allergy immunology physician, also have training in lifestyle and functional medicine, and I'm a certified life coach. I have been helping people navigate complex immune conditions like allergies, asthma, autoimmunity, and mast cell disorders for, 15 years now. And as someone who lives with Sjogren's myself, I'm always keeping a close eye on the latest research and treatment developments. Today, I'm diving deeper into the science behind Nipocalimab, based on a recent review article in the New England Journal of Medicine and some findings presented at recent rheumatology conferences. I'll focus specifically on the eligibility criteria that are being used in these clinical trials and also what we know about the safety and side effects from this research thus far. Now, if you missed our prior episode, you will want to go back and take a listen to that one after this. And if you are also interested in the latest in immune system health, Sjogren's disease, mast cell disorders, make sure you subscribe because that is what my channel is all about. Let's dive into the mechanism of action, or how Nipocalimab actually works, why it's showing promise for Sjogren's. We'll do that first, and then we will dive into the specifics of eligibility and the side effects that we've seen from clinical trials thus far. So let's understand the science behind this exciting treatment, Nipocalimab. Nipocalimab belongs to a class of medications known as the neonatal receptor antagonists. FcRn is going to be the acronym or the shorthand for these medications. FcRn, or the neonatal Fc receptor, plays a crucial role in regulating levels of our antibodies, and specifically IgG antibodies. These antibodies provide our immune system memory to vaccines we receive, infections we fight off, and often they are the type of antibodies that are our autoantibodies, or antibodies that our body makes against our own tissues in the case of Sjogren's disease. And this treatment is also being used for another autoimmune condition called myasthenia gravis. In autoimmune conditions like Sjogren's, some of these IgG antibodies are directed against our own tissues. So this is what we can see if you are seropositive, SSA positive, SSB positive, and or if you're checking that early Sjogren's profile test, we can see specific antibodies from that too that are directed towards our salivary protein, carbonic anhydrase, and a few others. Now, going back to this review article from the New England Journal of Medicine, this neonatal receptor is normally acting as a recycling system for our IgG antibodies. It protects them from being broken down, digested, and it extends their half-life, or it keeps them in our system around for longer. It also is how a mom will pass along antibodies from her bloodstream to the baby during that second and third trimester of pregnancy. But in this case, when we're using these medications, when someone is not pregnant, when we block this neonatal receptor, we are preventing this recycling process. And that is what Nipocalimab does. It blocks the neonatal receptor, prevents IgG recycling, and this leads to an increase in clearance of our IgG antibodies, including those that are the problematic autoantibodies involved in Sjogren's disease. What makes this approach particularly interesting is that it targets a specific immune system pathway without causing broader immune suppression, which can occur with other treatments for autoimmune disease. So taking this more targeted approach could potentially offer a better safety profile while still effectively reducing disease activity. The data published so far suggests that Nipocalimab can reduce the total IgG levels by approximately 70 to 80% when it's consistently dosed. And this reduction appears to correlate with improvement in clinical symptoms in these preliminary studies. And that is why that there is so much excitement about these ongoing phase 3 clinical trials, which have been fast-tracked. Now, one thing that we need to think about is what are the additional consequences of this lower IgG level. We're going to get to that at the end when we talk about the side effects. But first, let's talk about the eligibility criteria. Who qualifies for these trials? So, one of the questions that I got asked the most in that initial video was, would I qualify for this clinical trial? I am not affiliated with these clinical trials. I am not running this in my clinic. I am participating in a different clinical trial, the dasidalipep or OASIS trial. And so I do have some familiarity from that patient side and from the physician side for other clinical trials. But based on the published protocols, the clinical trial program that is studying nipocalimab in Sjogren's disease, there are some key eligibility criteria. You can find these by going over to clinicaltrials.gov. You can search for the nipocalimab trial, and these will be listed there. You also can contact the study coordinators directly to determine if you are qualifying or not. And typically, they will ask you some screening questions before they would go ahead and think about scheduling a screening appointment. So, what are these listed criteria that are published? Confirmed diagnosis. Participants must have a confirmed diagnosis of what they're still calling primary Sjogren's syndrome. We know it now as Sjogren's disease, according to the 2016 ACR-EULAR classification criteria. Now, we've talked about some of the challenges associated with this classification criteria, but when they are looking at these clinical trials, they need to be pretty rigid about the type of patients we are studying. And so this typically is going to require a combination of symptoms, positive autoantibodies, so being seropositive, and or if you're not seropositive, typically you will need to have a lip biopsy that has a particular focus score and or ocular staining score. So there are some pretty specific criteria there. The number 2 criteria is how active is your disease. They're looking at this treatment for moderate to severe disease. So that is where the EULAR Sjogren Syndrome Disease Activity Index, or ESSDAI, is going to be important. And this is a scoring rubric that is published, but it essentially takes into account the systemic manifestations beyond just dryness symptoms and looking for those. Number 3, symptom duration. Most trials are going to require that patients have had these symptoms for at least 6 to 12 months prior to enrollment. They want to find some folks who have established disease. They're pretty, active disease in regards to their disease activity with that score of 5 or higher, confirmed diagnosis, so that they can make sure we're studying kind of that prototypical group of people as we're seeing the initial studies for this medication in Sjogren's disease. Age is also a requirement. Initial studies are almost uniformly going to take place in adults, so 18 years and older, and typically there is an upper level cutoff somewhere around 75 to 80 years of age. Now, there are several exclusion criteria, so those are the things you need to be included, inclusion criteria. Exclusion criteria might prevent participation. So when they're looking at a new medication for a specific disease, they want to try to zone in and zoom in on people with just that disease and without other factors that may complicate how we interpret those results. So if there are people who have other autoimmune conditions like rheumatoid arthritis or lupus, oftentimes those patients may be excluded from these initial trials. Previous treatments also may exclude some people who have received certain biologic treatments within a specific time frame. So, for instance, I could imagine that likely rituximab is probably one of those treatments that they will not have wanted you to receive in recent memory, because rituximab also can affect your IgG levels in the cells that create IgG. So that could be a problem and could complicate how we see those results and understand those results in context. Other health conditions can also cause a problem. If you have significant kidney or liver disease, active infection like tuberculosis, for instance, or history of certain cancers or neurologic conditions, these also may be things that they want to make sure we're studying in a relatively homogeneous or similar population of people before we extend it on to folks with a little more complicated history. We also tend not to study new drugs in people who are breastfeeding or pregnant, people who are thinking about becoming pregnant, right? Because we want to make sure this medication is safe in non-pregnant people first. And then there usually is quite a long-term ongoing process in order to decide if or when it may be ethical to consider treatment in pregnant people, breastfeeding people. And then if you have a known immunodeficiency disorder or already know that you have a low IgG level, that is likely, that is an exclusion criteria. We're not going to give you a medication that's going to drop that level even further. Now, it's worth noting that each clinical trial site may have slight variations in their specific inclusion/exclusion criteria. It's really important, if you are interested and these generally sound like they might work, to reach out to those study contact people specifically. What's particularly interesting about this IRIS trial is that they are evaluating nipocalimab across a broader spectrum of Sjogren's manifestations than some prior studies. So they're not just following the classic dryness symptoms, they're also following how does this affect fatigue? How does this affect joint pain? How does this affect systemic organ involvement? And this really is critical because it is showing that we are recognizing, finally, that Sjogren's is a systemic disease that can affect us from head to toe, not just the moisture-producing glands, right? According to data presented at the recent rheumatology conferences, these trials also are including some patient-reported outcome measures that are going to capture how does this affect our quality of life? How does this affect our symptom burden? And I think that's really important when we think about how we're evaluating treatments for Sjogren's. I have been filling out many of these surveys through my own experiences with the OASIS trial as well. All right, so I think this is the meat of it. Okay, what are the potential side effects, right? What is the safety profile? Anytime we're thinking about a new medication, part of this process, right, is determining, is it effective and is it safe? So let's talk about what we know thus far about the safety profile and side effects of nipocalimab based on their published data thus far. So this is coming from phase 1 and phase 2 trials and kind of a summary of that data. So Fc neonatal inhibitor medications, receptor inhibitor medications, are a class that generally have shown a relatively favorable safety profile in clinical trials for other types of autoimmune conditions too. As I mentioned, these medications, including nipocalimab, have been studied in myasthenia gravis, and there are some other ongoing studies as well. But with any medication that affects the immune system, there are some important considerations. So one, infusion-related reactions. These can include headache, flushing, pain at the infusion site. Now, what's been shown thus far is that these reactions have been mild to moderate in nature and often get better with subsequent infusions. So that's what they've found thus far. These 3 clinical trials are going to study this medication in a bigger population of people, a little bit more variability in their underlying health conditions. So this will be an important measure to follow to see if this continues to pan out. Number 2, increased risk of upper respiratory infections. We're reducing your body's immune system through decreasing the recycling of those IgG antibodies. IgG antibodies give your immune system memory, not only to itself when it's malfunctioning, right? Those autoantibodies. It also gives you memory to colds, to your vaccines, your flu vaccines, those sorts of things. So you can see a slightly increased risk of common infections, particularly upper respiratory infections. Thankfully, these have thus far in these smaller initial studies been mild and responsive to standard treatments. Number 3, symptoms that you see a lot on side effect profiles, right? Headaches and fatigue. These have been reported in some participants, and it's difficult to really distinguish knowing that Sjogren's often is accompanied by headache and fatigue, which is causing that. But that will be something they will continue to monitor. And then gastrointestinal effects. Some participants have reported nausea, diarrhea, or abdominal discomfort in association with treatment. So there is a theoretical concern with these neonatal Fc receptor inhibitor medications, And that is really worrying about the increased risk of infections since they do reduce the IgG antibody levels. And those antibodies are very important for our immune system defense. It's important, though, to know that this reduction is temporary and it's reversible when the medication is stopped. It also does not affect other antibody types, such as our IgA antibodies, which are coating our mucosal tissues in our gut, and our IgM antibodies, which are kind of the first antibodies that are produced when we fight off an infection. These medications, and Nipocalimab specifically, do not affect our cellular immunity, which provide significant protection against viral infections, fungal infections, so forth. The trials have been designed very carefully for monitoring for infection risk. And so far, the data suggests that serious infections have been quite uncommon. Nonetheless, patients in these trials are undergoing routine and regular monitoring of their immunoglobulin levels, and they're being assessed for any signs of infection throughout the treatment period. Another safety concern is pregnancy, since IgG antibodies are actively transported across the placenta to provide passive immunity to newborns. So this is the immune system in part that your baby is born with. Medications that affect those IgG levels could impact that process, right? And then this is one of the main reasons pregnant people have been excluded from the trials, and participants are required to use effective contraception or pregnancy prevention as a part of the trial. That has been the same in the dazodalibep trial. It is worth noting that current phase 3 trials will provide a much more comprehensive analysis and safety data because they will include a larger number of participants and they will follow them for a longer period of time. And really, that is why this phased approach to clinical trials is really important. So where are we at and what do we expect next? With the Nipocalimab trial right now, and where are we and what should we expect in the coming months and coming years? So the IRIS clinical trial program for Nipocalimab in Sjogren's disease is currently in phase 3 testing. This is usually the final phase of clinical trials before a medication can be submitted to the regulatory agencies like the FDA for possible approval or for evaluation for approval. And this program consists of 2 main studies. IRIS-1 is looking at the primary effectiveness or efficacy and safety of Nipocalimab and comparing it to placebo, sugar water. That's in adults with moderate to severe Sjogren's disease. IRIS-2 is a long-term extension study that is going to follow those participants who were a part of IRIS-1 and who continue to receive Nipocalimab in order to gather that data on the long-term safety and efficacy after that initial IRIS study. These trials are currently recruiting patients at multiple clinical sites across North America, Europe, and other parts of the world. The primary completion date for IRIS-1 is estimated to be in late 2025, and preliminary results will likely become available before then. Fast track designation that Nipocalimab received to the FDA could potentially accelerate this timeline. As I mentioned in my previous video, that fast track allows for more frequent communication with the FDA and the possibility of a rolling review process. And if the phase 3 results demonstrate significant benefits with an acceptable safety profile, Johnson & Johnson would likely submit a biologic license application or BLA to the FDA. With that fast track designation, this review process might be expedited compared to a standard timeline. And in a best case scenario where the trials would show strong positive results and good safety, we could potentially see Nipocalimab available as an approved treatment for Sjogren's within 2 to 3 years. However, it's important to emphasize that this timeline is subject to many variables, including the strength of the efficacy data, any safety signals that might emerge or concerns that emerge, and the regulatory review processes. As we continue to follow for the development of Nipocalimab for Sjogren's disease, it's really important to maintain realistic expectations while still acknowledging the legitimate excitement around this potential treatment. The science behind neonatal Fc receptor inhibition is compelling, and the early data for Nipocalimab is promising enough to have earned this breakthrough therapy and fast track designation from the FDA. However, we need comprehensive data from that phase 3 trial to truly understand Is it helpful? And is it safe? If you're interested in possibly participating in these clinical trials, I encourage you to talk with your rheumatologist or your immunologist about whether you might meet eligibility criteria, if there are trial sites in your region. And even if you don't qualify or choose not to participate in a clinical trial, staying informed about emerging treatments is an important part of being an advocate for your own health. I am incredibly hopeful for the future of Sjogren's disease treatment. And while this journey isn't easy, you're not alone. I'm here to support you, and there is a wonderful growing community of people walking this path alongside us. Be sure to connect with the Success of Sjogren Sisterhood Facebook group over on Facebook. It's a free support group. It is open to folks of all genders. We just say sisterhood because of the culture and warmth and that is there. There are tons of great resources and connections. You also can download my free Sjogren's Superhero Starter Kit. It is packed full of valuable tools, tips, great resources, other sites and things that you need to know about that have really been critical in helping my patients in their journey. I'll put all of those links in the description of the video below. And remember, I am accepting new patients in my direct care practice. I'm licensed in about 15 states now. If you are looking for a physician who understands inflammation, autoimmune conditions, both professionally and personally, I'd be honored to be a part of your healthcare team. The link to schedule a consultation is in the description as well. And in the meantime, what questions do you have about clinical trials? What questions do you have about Sjogren's disease and treatments? What's giving you hope? Share your experiences in the comments below. Don't forget to subscribe to my Sjogren's friendly tips and videos so that you don't miss our next update. Thank you for watching, and I can't wait to see you next time.